All right, good afternoon, group. I'm Gillian Grafton, and I'm going to talk to you about severe cardiomyopathy today. Sorry if you came for cardiogenic shock. We are going to do some questions, and you guys are going to read the questions, so please pay attention. I think you have some answering. And you're also going to read some echoes for me. No disclosures. This is a picture of what I feel like my life is right now, where I'm hoping it to be between two large land masses with a little bridge. All right, who's up first?
Sorry.
PJ, read the question, please.
6-year-old male with past medical history of non-ischemic cardiomyopathy. The patient is presented today to the ED with worsening symptoms of dyspnea, lower extremity swelling, and abdominal pain. He was found to be in significant fluid overload on examination. The patient reported that his symptoms have been chronically worsening with no acute flare-up recently. He admits that at his good days he is able to function independently and he is able to take a few flights of stairs without a stop. He is positive orthopnea and has been sleeping in the chair. Positive cough, no fever or chills, denies sick contacts. Medical regimen includes steroids, which he reports he is taking every day twice a day. And in addition to hydralazine, Indor, Correct, and Aldactone. He reports compliance with his medications.
So the question is going to be, you get this call in the middle of the night with this echo. What do you do? So what do you see?
It's a huge LV that we see. And the septum's kind of a little more over to the right. And of course you're not contracted. He has hardly any EF.
Okay. So peristernal long axis. You guys are doing ultrasound today? So peristernal long axis, just third or fourth rib space on the left side of the sternal border, and with the indicator to the right shoulder. And now we change the indicator to the left shoulder, and you get the short axis, and more of the same. Can't really see the RV here, and a large LV with poor function. And then PJ, what do we see here?
So this is the four-chamber view. Once again, the septum is really flattened. There's hardly movements of the left ventricular walls. Just the septum seems to figure. Other than that, pretty much the same as the last cuts.
Okay. What do you think about the RV here?
The RV seems, it's not fully in view, but what we see of it seems kind of small, not fully dilated.
Okay. Just be careful when the LV is that big. It makes the RV look a little bit smaller, but I think comparatively it looks okay. All right, so what do you do when you get the call from the resident that said, I got these great pictures? What do I do? No? All right, we'll go. So, and that's totally the right answer. The big thing is we can see an echo that looks really badly, but really, what does the patient look like? So he was warm to touch. All these guys' blood pressures mostly kind of in the 100s. His heart rate, he was on beta blocker, so kind of in the 70s. Short of breath, but he was not hypoxic. He was diuresed about 10 to 15 liters, and then this was his right heart cath just after, during the same hospital stay. So we can see that you can have a really poor EF and a really bad looking heart, but if we try to optimize them with medications, we can make them actually have a cardiac index. All right, here's another one. Who wants to look at this one?
LV seems to be hypertrophic. Seems to be contracting relatively well. Same with pericardial shock.
So what view is this? Mm-hmm. So RV, LV.
The IVC is kind of enlarged on that one. Not the IVC, sorry. The septum.
Yeah, it's a little thick, yeah. What else looks abnormal? Yeah, they're massive. So then what's your next question? When was her heart transplant? So heart transplants will have these enormous atria because of the way that they attach the atrium back. So you get a little bit of both your original atrium plus the donor's atrium, and so you get these giant atria. All right, so who wants to guess what this patient's RA pressure is based on RA, wedge, and cardiac index?
15.
The RA, okay. What's the wedge? I mean, I'm giving you just have to kind of get, like I just give it. And cardiac index? So essentially, you can't really tell much from just looking at the echo. This patient at the time had a PEA arrest, and this is a post-PEA arrest echo, so still had actually pretty decent function, but really a graft failure transplanted 16 years ago. Anybody want to read her? Him?
70-year-old male patient with Cardiogenic Shock cardiomyopathy with higher coronary artery bypass graft in 2000, independent diabetes, CKD stage 3, CHF is systolic and diastolic dysfunction, EF of 20-25% followed by advanced heart failure. He presented with increasing fatigue, dyspnea exertion, shortness of breath at rest. Decreased appetite for the past 2 to 3 weeks. He also reported some epigastric discomfort, though no overt chest pain. Is currently breathing comfortable, resting in bed, no chest pain at this time, no shortness of breath while laying in bed. Said EF was 20-25%.
That's what the report says.
Yeah, that's probably like 10.
So you guys don't get that benefit, but we see reports sometimes we're like,
Yeah, I think is there a pericardial effusion possibly?
what do you think?
Pleural effusion.
Yeah, pleural. Okay.
And same thing. He has probably no forward flow at this point.
So what do you do with this guy?
So it looks like he has class 4 symptoms. Shortness of breath at rest. With that echo.
And he's warm. He's perfusing, but just he's class 4 symptoms.
Have you seen the patient?
The resident says he's warm.
Oh.
Okay. So again, like, you have no idea. And so despite perfusing, he still had a pretty low cardiac index. And we'll talk a little bit more about it, but what should be, when you get this patient, what should be the next question you ask the the physicians that call about the right heart cath numbers. You got to call them. These are the numbers. What's the next question typically asked?
Was there LVEDP or?
LVEDP was 8.
Like systemic pressure, then what were they setting systemic?
So yeah, that's the big question, is because that's really where our next what to do with these patient goes. So he actually was put in the unit. He had a blood pressure of 110. He was started on nipride, and really within just 48 hours, his cardiac index with increasing afterload reduction was 3.39. So that's why we actually can make big changes in cardiac index and cardiac output with afterload reduction, and that's why milrinone is important when you need it, but we can also do a lot with afterload reduction. Yeah.
So this guy had normal blood pressure, I'm guessing?
It was like 110, systolic 110.
So if he was, I guess he was, shocked and he died before that.
Yeah, and so even despite having a really low cardiac index, if he's perfusing, then he's not actually definition of like low perfusion shock. And I think that's the hardest problem is when you see these patients with really low EFs, like what do you do with them? And if you have other signs, you really need clinical signs of shock or malperfusion to be shock. So decreased urine output, ultramental status, and cold extremities. And we kind of joke that when I go to see these patients right after getting that call, shake their hand, because then that will tell you the temperature of their hands, touch their legs, and that will give you a lot of information and asking how they're doing. So, any questions about those? Okay. When we talk about cardiogenic shock in trials, we put a little bit more hard numbers, and so systolic blood pressure less than 90 for greater than 30 minutes, or requiring vasopressors to get to that, and then again, ultramental status, cold extremities, low urine output, and lactate. A couple of quick slides on the shock trial. Really the thing to remember about this is it was a trial that looked at 300 patients, randomized to 150 to revascularization, 150 to medical management for acute MI coming in with shock. Most patients got a balloon pump, just so you know, and most patients were on vasopressors. And then the revascularization was PCI most of the time, but also bypass. And really what it found is mostly if you're young, you have acute MI, and you're in shock, revascularization is the thing to do. So I think really what this is telling me, it's important when you have really sick patients that we still are looking for that acute myocardial infarction that we can do something about with revascularization, because that's really the best treatment for cardiogenic shock. And
in that trial, they defined MI as by troponin pump or EKG changes?
Yeah, both.
Okay.
And so it's showing again that despite really pretty aggressive therapy on both sides, revascularization is the way to go for treatment of shock and mortality benefit. And this is just showing really most of the group, other than patients over 75, do better revascularization. This was kind of the follow-up shock too, and really trying to look at the balloon pump support a little bit more. And I'm just going to give you one more slide. Essentially, you guys know that this is where we decided that balloon pumps are of no benefit. I say that a little tongue-in-cheek, but that these were patients, again, in cardiogenic shock from acute MI, and whether they got balloon pump or no balloon pump. And really there was no change. So prior to this study, they felt like balloon pump, it was a class 1 indication for cardiogenic shock with acute myocardial infarction. After this trial, it got downgraded to 2A indication. So I think this is a question that comes up a lot for me, and we think about it a lot within the kind of cardiology division, how should we really treat these people that come in with severe cardiomyopathy or shock? So this is the kind of a simple table that, but I think says a lot. Is when you go to see these patients, it doesn't really matter what their echo is showing, to be honest. How are they looking? Are they, do they have congestion? Are they dry or are they wet? And then are they perfusing? Either not perfusing and dry, or perfusing and dry, or so you can see. But the reason this is important is because there's a significant change in mortality depending on what kind of square you're in. If you look here, I would just take this L out because it was like 9 patients and really not, they couldn't really look at it, so I would just take this part out. So it is thought, though, that maybe dry and cold is the worst place to be because you're not perfusing and you really are euvolemic. And so there's not a lot we can do other than inotropes and advanced therapies. In this chart, when we take L out, C is by far the worst. These are a group of patients that we end up giving inotropes a lot to, but sometimes once we get them to more of a euvolemic state, they are perfusing a lot better and they are on their merry way, although they are very high risk for requiring advanced therapies in the future, LVAD and transplant. So again, there's a big difference when we're talking about, this should be most of the general kind of cardiology patients, the shortness of breath, but these are the 2 groups that we have to separate a lot. So one of the ways to think about this, and sometimes it's still difficult, is if it's congestion and if they have blood pressure, vasodilators are really the way to go. If they're not perfusing at all and they are kind of really in the true shock state, those are the times that we go to the inotropes. This box right here, this cold and wet, that needs both vasodilators and inotropes, is, I think, the box that we use milrinone for the most because you get some of that vasodilation along with the inotrope. And I think that's why you see us with so much milrinone in that box. Does that make sense to you guys? So just a quick table. I just want to pick out some things from here. Really, we're comparing dobutamine and milrinone. Dobutamine has a really short half-life, so it's nice because if you have problems, you can turn it off and it's gone. 2 to 3 minutes. Milrinone is a little bit longer at 2.5 hours. So that also means that it can build and build, especially when you have patients with decreased renal function. You end up getting pretty high doses of milrinone in the system. The one thing is, though, in that box that I showed you that you have congestion and poor perfusion, dobutamine will give you some inotropy, but really it doesn't have the ability to decrease the SVR. So you really want to think about, if you're requiring to use dobutamine, that you're really aggressive with other afterload reducers. And then really the main thing is milrinone, you have to be careful. It can give you more blood pressure, hypotension, and dobutamine tends to give you a little bit more tachycardia. It's also thought that dobutamine doesn't work as well in patients that are on chronic beta blockers as an outpatient because of the change in the beta receptors. Anybody have questions or problems or concerns? Yeah?
With dobutamine, so there's the concern with the ischemia getting, it's a trade-off, like you this benefit that you just...
Yeah, they actually both will increase oxygen demand, and so that's one thing that we have to think about in patients that are in acute myocardial infarction, and probably mechanical support is probably better for those people, but they both will increase like oxygen requirements or oxygen use.
Dobutamine, what is the reason why you sometimes can get hypotensive if it doesn't make the SVR?
do you get hypotensive?
Sometimes you get
Hyper or hypo? So sometimes it is, I think, because you get the tachycardia, and then you're not getting the left ventricular filling, and then you don't. But it really will give you a lot less hypotension than the milrinone. And then the vasodilators, just kind of briefly, nitroprusside is both an arterial and venous vasodilator, so then that allows you to treat the afterload, which we're looking mostly for, but also can give you some decrease in the preload. The problem is it's titrated in the intensive care unit with an ART line, so that can make it difficult. It has toxic metabolites and cyanide toxicity, but we have some tools to kind of help monitor that. And then you can get this coronary steal phenomenon that you'll see in the notes. And really what that is if you have a fixed obstruction in the coronary artery and then you're vasodilating everything else, that fixed obstruction is unable to open, and so then you get kind of a relative you're actually decreasing the percentage of blood flow through there because it's unable to vasodilate that part of the blood vessel. We see it, and it's in all the literature, but I don't think that clinically we think about it as much as we see it in the literature. Nitroglycerin really is a preload reducer. You can get tachyphylaxis, meaning that you're just increasing doses. And patients, you can get a lot of hypotension. I think it's because we tend to titrate it faster than nipride, and then because we're not really getting benefits from the heart failure standpoint, and then patients tend to have much worse headaches from nitroglycerin from my experience. Again, I think it's because we're using higher doses because it's not as, it doesn't work as well as the nipride. And then we have our kind of go-to ACE inhibitors, ARBs, hydralazine isosorbide dinitrate, and then the new kid on the block, the neprilysin inhibitor, Entresto, which is a medication that it can cause a lot of hypotension, but if your patients can tolerate it, patients feel actually a lot better on it, and I think it's because of the really significant vasodilation you get from it. All right, who wants to read another question?
36-year-old woman, G3 P2, 37th week of pregnancy, comes to the labor and delivery emergency clinic with the gradual onset of steadily worsening shortness of breath over the past week, which has worsened markedly over the past 24 hours. She reports the inability to lie flat and worsening lower extremity edema. She reports subjective low-grade fevers, but did not take her temperature at home, and a cough productive of mostly whitish sputum, with some pink tinge to the sputum on the day of presentation, which allows chest control.
All right, the question's going to be, well, here we go. Essentially, what is this? But go.
On exam, she's in moderate respiratory distress, vital signs, heart rate of 120, respiratory rate of 18, blood pressure 180 over 70, temperature 38, saturation is 91% on milliliters, positive AZ, Grafton, tachycardia, gravity uterus, plus ventricle, white count of 12, above the 10, so it's 150, but
Okay, so these questions coming up are ABIM ones, so you'll see. But essentially, peripartum, it used to be called postpartum, but now we know that patients also get it during pregnancy. Heart failure within the last month of pregnancy or within 5 months of delivery, and really the absence of other etiologies for their heart failure. There's differing, based on different studies, how often it happens, but one per about 2,000 to 4,000 live births in the United States. Risk factors: advanced maternal age, African descent, multiple gestations, history of hypertension or preeclampsia, prolonged tocolytic therapy, obesity, and lower socioeconomic class. And the treatment really is as an outpatient, diuretics, nitrates, and then if you need more oxygen, non-invasive ventilation, and inotropes. So this, we see so many sad cases. I just wanted to go through. This is a patient we had a couple weeks ago. She came in, she had a normal pregnancy 3 to 4 weeks ago, came in with 4 to 5 days of shortness of breath, no history of any heart disease, and this is her echo in the emergency department. So parasternal long axis, not much of her heart looks to be moving at all. Sorry, I missed the punchline here. So 24 hours after coming, she crashed. She got coded for 2 hours, was put on ECMO for about 2 weeks. We really had a hard time trying to figure out what we should do with her because she didn't look like she was going to be a candidate for advanced therapies. And then this was her echo most recently, and she's like up and walking around and looks really great. So it really was a true save. And one of the things that happens sometimes with the patients crash so fast, those actually, if you can support them through that period of time, tend to be the cardiomyopathies that are able to reverse. So.
Any data in induction of delivery that assists with this recovery, or
The type of delivery?
I mean like inducing delivery or having delivery during this recovery, if that's all an ECMO or something.
It doesn't change like the outcomes.
So what was done for her besides ECMO? Anything else?
Time.
Time.
Another long stem question. Anybody?
71-year-old woman comes to the ED 2 days after a prolonged episode of chest discomfort. Her past medical history is significant for diabetes and hypertension. She's pain-free participant. Her heart rate is 110 beats per minute. Blood pressure 95/70 with respiratory rate 24. She has bilateral basal crackles, S3 gallop, and a 4 out of 6 left side holosystolic murmur with throat and radiation of the apex. EKG shows right bundle block with Q waves in leads B1 and B3. Chest radiograph reveals borderline cardiomegaly with pulmonary vascular congestion over the posterior lung fields. Bedside echo reported as showing decreased LV function without evidence of pericardial tamponade. The RV is not well visualized. The patient is given a bolus of Lasix but has minimal output. She becomes more dyspneic and her blood pressure falls to 80/60. Transferred to the ICU and PA catheter is placed with an RA followed PA pressure 44/30 with a wedge of 18, the cardiac index of 2.6, mixed venous side is 80%, SpO2 is 94%.
So I'll let you guys look at some of the buzzwords from this stem. The question is going to be, what's the diagnosis? That's good. So I feel like I was asked a question that had these 3 answers probably 10 times on the boards this year. So that's why I'm bringing them up to you guys. All right. So what I've tried to do is pick out some of the words that you'll see in the stems for some of these complications. So this was a VSD. When you look at the old prevalence, it was more in the 1 to 2%, but now with PCI and early revascularization, that rate has decreased. Usually happens 3 to 7 days post-MI, and really what it happens when you have a large anterior infarct, and then that muscle starts to die off, causing the muscle to essentially disintegrate. You see this little tiny vessel right here, so that's the LAD that comes down through that groove, and so you can imagine that when that's blocked, that this muscle kind of dies off, and that's how you get the defect. So you'll hear a new holosystolic murmur at the left sternal border. You can get some conduction delay because the conduction system comes along the septum right here. When they talk about this step up in the oxygenation, essentially you're getting a left to right shunt of oxygenated blood, and so your mixed venous sat is going to be a lot higher than you would have anticipated, and that's what was in that stem. And when patients present, they'll be hypotensive, pulmonary edema, and cardiogenic shock. Any other questions about that, you guys? So another thing that you will see on the test is the left ventricular free wall rupture. Half the time it will happen within 5 days, and most of the time within 2 weeks. Patients will have had a large myocardial infarction, and then they're kind of seem like they're getting better, and then all of a sudden they'll have this really sudden onset, chest pain. They'll have all the symptoms of heart failure, but also tamponade. And really what's happening is just like the septum, you're getting this rupture here, and then blood goes into the pericardium here. As you see here, filling up with blood and acting with like tamponade physiology. So you get the pulsus paradoxus, decreased heart sounds, tachycardia, low voltage on the EKG. Sometimes what you also will get so this is an aneurysm, so the wall stays intact, but this ends up being scar, and you get this outpouching. But a pseudoaneurysm is when you actually have a rupture, but for some reason it's been contained in this small area in the pericardial space. And so that's when you'll see buzzwords as like to and fro murmur, because the blood is just kind of going in and out. Tachycardias. You can imagine that with the stasis in here, you get blood clots, and then every so often it gets kicked out, and then so you get the systemic embolizations. And then one of the other things is you'll get this persistently elevated ST segments. Those are times to think about this pseudoaneurysm. These are all medical emergencies, and this has a very high rate of rupture. So I just saw this picture. I've never actually seen this, but you can kind of see in the x-ray that the heart doesn't look the way it should, and it might be something to look into echocardiogram if you see these kind of weird bulges in places that aren't typically there. So papillary muscle rupture, I would say, is the most common. They say that 7% of patients that present in cardiogenic shock after MI will have a papillary muscle rupture. It used to be thought that it happens a few days out, but now with the reperfusion, they're saying that it actually happens earlier. I'm not exactly sure why that is. It usually happens, so you can imagine the RCA, it comes off around here, and it will kind of come around the bottom of the heart and then come down this groove at the bottom. There's only a single blood supply to this posterior papillary muscle, so this is usually the papillary muscle that will rupture, and for some reason boards love questions like this. So single blood supply to the posterior medial papillary muscle due to inferior myocardial infarction, and they'll have really bad pulmonary edema and CHF. They will sometimes trick you by saying they don't hear a murmur, but it's kind of like when you have severe tricuspid regurgitation. When you have so much regurgitation, then there's not a significant gradient, and then you don't hear the murmurs. So this is just still picture, but this is the leaflet that's bowing up into the left atrium, and then sometimes you'll see this big glob on the end of the leaflet, and that's the head of the papillary muscle.
He has had a known non-ischemic cardiomyopathy for several years and has been treated with diuretics, digoxin, ACE inhibitor, beta blockers, and spironolactone. He had been doing fairly well, but has been hospitalized 3 times in the past 6 months. He was given IV Lasix in the ER, admitted to the ICU with the PA catheter space, and treatment with melanoma 0.25 is begun. The next day, the patient is improved, but still dyspneic. He is can't say the word, and looks depressed. The blood pressure is 80/60. Heart rate is 106. Left rate is 25 basal factor is 8. His apical impulse is diffuse and laterally displaced. He has 2/6 hollow systolic murmur at both the left lower external border and the apex, and S3 gallop. His extremities are cool, but he has no feeling about. He had a number RDA pressure 8, RD 40 over 8, PA pressure 40 by 22, wedge of 18, a cardiac output of 2.6, and a cardiac index of 1.8 while on liver.
Okay.
Once you see that, it's such a hassle.
Yeah. All right, so this guy meets all criteria for transplant. We'll talk about it in a second. So one of the things that comes up a lot is they look okay on milrinone and feel a lot better. It seems a lot easier than LVADs or transplant. Can we just send them home on milrinone? The answer is yes, you can send them home on milrinone, but this was on a study that's from 2003 and really still is pertinent. It's kind of a meta-analysis. So the open shapes mean no milrinone and we're sent on oral therapy, and the filled in are milrinone, and this is mortality versus duration of therapy. So really no difference. It doesn't help your life. It probably decreases your life expectancy. It can make patients feel a lot better and they can get around and do a lot more, but really, even though they feel good when they first start the medication, it does not extend life at all. So just briefly, indications for heart transplant, really refractory shock, requiring mechanical or medications, a peak VO2 less than 10, New York Heart Association class 3 and 4 despite maximal therapy, including CRT, and then life-threatening arrhythmias, sometimes in people with severe VT storms. The patients I've seen with this are old, or sarcoid patients can be kind of in this category. End-stage congenital with no evidence of pulmonary hypertension. I feel like this doesn't happen very often, but that is one of the indications. And then a refractory angina. I've never had a patient transplanted for this, but it is and remains in one of the indications. So just briefly, all the tools that we have for mechanical support. The balloon pump, which is the most common and really, I would say, the easiest to place and to manage. A catheter goes in through the femoral artery. A balloon is placed up into the aorta, and it inflates during systole, it inflates during systole, and it inflates during diastole. It goes down during systole, and so really, it's the strongest afterload reducer that we have, because when it blows up and then comes down, it really decreases the afterload and encourages the blood to be exit the heart. The Impella, some people really like it, but essentially it's a catheter placed into the femoral artery, goes up in the aorta, crosses the aortic valve, and just sits here. There's a little, essentially, motor on it that will suck blood from the left ventricle, and then releases the blood out here in the proximal aorta for cardiac output. I have cardiology fellow PTSD from this because they're moving constantly. They get caught up in the mitral apparatus. They clot. They alarm a lot. Oops. The tandem heart is another device that there's one catheter that will go in the venous system. It goes all the way up the inferior vena cava, and it's a complicated procedure because it has to cross the atrial septum right here. So it's drawing blood actually from the left atrium, goes down through this pump, and then put back into the femoral artery. And then ECMO, which I don't think we'll have time to talk about, but essentially an arterial and venous cannulation. Quickly, the more durable devices, the HeartMate 2. So outflow goes, or the inflow goes into the left ventricle. You have an axial pump here. This rotates and then essentially pumps blood back into the aorta. Driveline comes out through the abdomen here to a controller and batteries. The newer HeartMate 3 is a centrifugal circulation or pump flow. So this whole device for this and the HVAD is within the pericardium, so much smaller than this device that actually has to sit kind of near the diaphragm. The same controller and batteries. So this one's magnetically elevated, so it sits here, and then there's thought to be more of a space here to let more blood flow, hoping to decrease the amount of hemolysis. And then this is kind of the competitor HVAD, same type of thought. This is the total artificial heart, if anybody is interested in it. It is syncardia. So essentially they cut off the atrium right here. Yeah, like right here, and then this is your whole heart right here. The thing that's nice about it is that it's one machine, so both sides are talking to each other, but there's a lot of hemolysis because there's valves within this. This is a pneumatic pump that blows up air, which then pumps out the blood to the various chambers. So the reason I'm going through this is because I had multiple questions on LVAD in critical care boards too. Yeah.
Were there questions? Oh, sorry, you were saying something. So the bypass of ECMO, so they things like RB failure after having an LVAD?
So it's a centromag, so it's just it's almost like the tandem heart. It's not exactly, but it's almost like this is what a centromag kind of is, except so they're just essentially putting a cannula in here. It goes through a pump outside of the body like this, and then they'll put it back into like the PA or something. So sometimes they're putting LVADs in the left and the right side. The problem with that is they don't talk to each other, and so it can cause problems. So bleeding, VADs are a very complicated thing, but they're actually pretty easy as far as complications. Bleeding, thrombosis, infection, RV failure. They also get this suck down phenomenon, pump dysfunction, and hemolysis. So this was another ABIM question, or seat question, so you guys.
30-year-old woman has cardiogenic shock and is found to have an ischemic cardiomyopathy with severe systolic dysfunction. Heart rate and continuous flow, and that is placed as a bridge to potential transplantation. Immediately at 5 mics per kilogram per minute, and treatment are initiated, and she is returned to the ICU. We were called to the bedside for onset of VT at a rate of 200 per minute. NAP is 75. With this rhythm, the LVAD resets itself to the preset speed limit of 9,000 RPM with decreased power and pulsatility index. You administer epidural and the patient reverts to sinus rhythm with no change in hemodynamics. The LVAD is slowly resetting itself to the original settings.
So what's happening? Anybody know? A lot of you got it right. So there's suck down. So really what suck down is, this is what you want it to look like. This is the left ventricle, this is the cannula. But if you're running speeds that are too high, then the ventricle gets, really you're draining it too quickly. The flow is too high. So then the ventricular wall will collapse back down on the cannula, and that's how you get ventricular tachycardia, you get this low PI and low flow, or high.
Could you explain the response of the LVAD to the VTAC itself?
So it's getting VTAC, so when that wall hits, the VAD has been programmed to say that's probably a suction event, so decrease the speeds to allow the ventricle to fill again, and then I'll try to ramp back up. Last question, I think.
66-year-old man with ischemic cardiomyopathy underwent destination LVAD for heart 2 3 months ago. His home medication included furosemide, diazepam, carvedilol, and warfarin. For the past several weeks, he has noticed increased fetal edema and dyspnea walking. Review control data reveals that LVAD power has increased from 7.9 watts to 10 over the last 3 months. Over the last 5 weeks. That's right, over the last 3 visits over the last 5 weeks. There has been no change in the pump speed. INR been 2, LDH is 1300 1 month ago, and LDH now is 900.
The LDH is 1300 and was 900, yeah. So yeah, pump thrombosis. Anytime you see high LDH, just think pump thrombosis. That's really what we follow. I know you guys won't be able to, but increasing power as there's a thrombus in the pump's requiring increasing power to get the blood flow. So that's another kind of tip. But really, if you see elevated LDH, just think thrombosis. So these are just a couple of actually recent ones. You can get this kind of thrombus. This was the part that was in the ventricle, so kind of along that inflow. But the most common and one of the biggest problems with the HeartMate 2 and this axial flow is you get, because this has contact with another part, you get heat, and heat causes these, slowly causes like denaturate, essentially changes that cause this clot to form, and it will slowly get bigger and bigger and bigger, and then finally affect the pump. So that's really why the VADs have gone to more that centrifugal type flow, because this is a really high risk of clot now with the HeartMate 2. So we're really kind of going away from the HeartMate 2s. They're horrible and they have a lot of complications, but really, I mean, this is kind of the most recent. These are HeartMate 2, the most recent pumps, and this is mortality if you're doing optimal medical management. So still a big difference with the right patient population. And this is just the same thing, cleaner LVAD versus, and this is destination therapy, so people that are not candidates for transplant who tend to be sicker and have other comorbidities versus medical management, so still a big difference. And this is just a quick visual analog scale that patients say, if this best health imaginable, worst health, and they kind of pick where they feel like their health is. This is after VAD, or this is before VAD. That patients actually, I think this is, I forget now. Yeah, patients that felt worse. Sorry, this is medications, VAD. If you felt worse, which was a low score, that if you had VAD that you got better, and if you just had medical management, obviously you didn't feel better and maybe felt worse. If you felt good before VAD, then the complications and the problems with it don't really outweigh the risk. So we really want to focus on people that unable to do the things that they would like to do with severe cardiomyopathy. So just quickly, cardiogenic shock is still really bad, high mortality. Images don't tell the whole story. Physical exam can tell you a lot more. Always consider revascularization if possible. There's a lot of options for mechanical support nowadays, and VADs aren't all bad. Questions? Yeah.
So, for us as intensives, when we get those patients, like when they get sick to the ICU, like patients like on Impella, patients on some sort of cardiac support, and they have circulatory compromise, do we give them like the same types of support, like regarding the pressors? Do we do any changes, like in management of those patients? And what happens in cardiac arrest? How we handle it?
With VADs or?
With like Impella.
The
like
same.
The things, the temporary. So if the patient coming on Impella and the patient is still hypotensive, so does it mean that the Impella is not working, or we continue with the pressors and treat the other cause? But how we think about the Impella is the cause, or?
No, I wouldn't think of the Impella as a cause, but what I would do, I mean, I think everybody do different things, but I would get all the pressors and everything that you know how to treat those patients, and then try to troubleshoot the Impella. So a lot of the Impella, they alarm like nonstop. So if there's small changes in, like, whether they're getting clot or they are malpositioned, they'll alarm a lot, which will tend to say. If it's not, and you're still having problems, then it just might not be enough support. It's amazing when you get that support on how much you can come off the other meds, but if you can't, you can't.
And during the cardiac arrest, what we do, like, we turn the Impella off? And
I would turn the Impella off, because it's going to clot anyways, probably, and then do normal chest compressions. There is, I'll say that on all the doors of LVADs, it says no chest compressions. That's actually like a controversial thing. Like, some places do chest compressions because we're talking about a patient that is in cardiac arrest. So you might go to a different place and they do chest compressions on LVADs. That's just really site specific.
I was going to ask about the chest compression. So they, AHA just put out that guideline, and O'Neill's name is literally on it. So, and they had recommended chest compressions within that, and within like a scope of an algorithm. But is there any kind of movement on our end, like people here want to do that, or?
There's talk about it, like it's been brought up. It's just, I think the official hasn't changed.
The official is done.
Anything else?